I'm sorry? Okay, very briefly, standards. The good news, they're converging. The reality is that provincial standards are often written in isolation, even between regions in Alberta. For an example, you'll find differences in standards between the Capital Region and the Calgary Region. There's an inclination still to deal with standards which are on the horizon as opposed to those which are writable today. For an example, originally in Alberta they decided to go with HL7 version 3 for an implementation March of 2004. Version 3 hasn't gone through the audit process in HL7 yet. So those things are becoming a great barrier. Where am I think I'm running a little out of time. The Canadian industry fit, and I'll go through this very quickly. Number one, I think the biggest thing that we're starting to recognize that the marketplace has changed enormously. It is no longer a transaction between a vendor and a facility. It is a transaction with a vendor and a strategy. So that, at least in Alberta, one has to look at the provincial strategy. The customer has to take that into account. Products need to be consistent with requirements, as I said before, between regional and provincial initiatives. I think the critical success factors will include a really in-depth knowledge of the client business, that there will have to increasingly a harmony between the vendor's knowledge of product and the business that their clients are in. And very, very much like the physician office environment, just very much like lab vendors have always known a great deal about how labs work. Radiology vendors or radiology systems vendors have always known that. Pharmacy, I think we're going to start to see that in other clinical systems as they come about. Vendor viability, I think, is already becoming a very increasing factor in terms of selection. And on the other side of things, I think vendors will take a much more serious stance in terms of qualifying customers. RFPs are getting very, 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 very complicated and very expensive to respond to. And I think I know for a fact that a number of vendors have from some of these RFPs have simply walked away from because there's absolutely no guarantee at the end of it, and the investment is simply not worth their time because there's some real customers waiting on the other end. And Canada, by the way, is noted for tire kicking. That, well, we'll see what's out there, and you go put vendors through an RFP process, and there's nothing at the end of it. There's no guarantee that there's even a contract going to be let. And that's an abuse of the system, in my view. Where do Canadian vendors sit? I think that the HIS, or the total enterprise marketplace, is gone for us. I think the Americans have it all, and the reason why the Americans have it all is because the Americans have gone global. You see outfits like Cerner, like McKesson, like Per Se, any of the majors are really in a global environment, and I think we're lost to that. I think the new entrants to this global HIS vendors will likely be the companies like Siemens, Philips, the big multi-billion-dollar multinationals who are going to try to leverage their existing DI systems or lab systems into the HIS marketplace. I'm going to skip through, I think, the Canadian strengths. That's right with you. Canadians actually in Canada. Oh, okay. Oh, that's right. Threats and challenges to the Canadian IT community, I think, is common. Is the following: we have a made-here syndrome. It's the opposite of it ain't made here syndrome. But somehow Canadians have absolutely no faith in Canadian products. That if it comes from Canada, it can't be as good as something that comes from the U.S. And I can tell you from personal involvement, for BDM, for an example, which was recently bought by GE Medical, probably is one of the finest pharmacy systems in North America. First customer, a U.S. university. Canadians wouldn't touch it. As a matter of fact, Dallas Howe, who's the president of the company, said when he first went to Toronto to try to sell the BDM pharmacy, the guy said, "Where are you from?" "Saskatoon." "Where's your test site?" "Oh, it's so-and-so's pharmacy in Moose Jaw." The guy just looked at him, "Go away, I don't want to talk to you." He talked to a guy in Boston and hit the American market with full thing, and then was able to sell his product in Canada using the Boston firm. Same product. And that's happened over and over again. So that's one threat and challenge. The second one is financial stability. I think Canadian companies have suffered enormously from the IPO syndrome, this need to go public. Many of them got caught right in the middle of the process when the funding went away, and those that recovered, I think, are still floundering from lack of money. The third one, which I think or the fourth one, which I think is almost dangerous, is the one solution syndrome. I think this is going to hurt us enormously. That there's a growing pressure to move to a single vendor integrated solution, and that will do an enormous harm to supposedly best of breed solutions. That in the interests of having an integrated system, we will give up some quality. And one can only hope that seamless integration will be a viable and a recognizable viable alternative to that, so that one can introduce best of breed solutions within an integrated environment by going seamlessly. The other one is, I think, the challenges that Canadians have to face is the growing need to develop partnerships, alliances, and consortiums to compete effectively against, or to compete effectively in large and comprehensive contracts. The other thing that Canadians need to know, they have to understand what marketing is all about. I think if I have one editorial comment about Canadian companies, they say, "Well, I'm great, everyone should know that." And then wonder when they lose, when no one has ever heard of them. So I think, if I may, I'm going to skip up or two. Yeah, I'd like to talk about a few innovative areas. So if we can maybe move to that. I'd like to talk about, and I'm sorry, I sort of got lost in the timing thing, is one back. I'd like to play that little thing. This is sort of a cool way of implementing a multitude of very new technologies. It's done by, this was started as a project at Harvard Medical School and deals with a very highly specific area, and that's neonatal intensive care. The results of this project, or the use of this project within a very limited patient population, go ahead and play it. Reduce the
Thanks to modern medicine, premature infants have their best chance yet of surviving to live a healthy life. And now, thanks to modern communications, parents can be with their newborns every step of the way. That's tonight's Sunday cover. Parents in touch with their hospitalized infants online.
Alex was born just shy of the 6-month mark of the pregnancy, so he was only 2 pounds and 27 weeks when he was born.
It is a big, big shock, and he was very, very, very small.
In the days after the premature birth of their son Alex, Jennifer and Frederick LePap were barely hanging on.
It was definitely touch and go, probably about 10 days after his birth.
Then they learned Alex would spend the next 3 months at Boston's Beth Israel Neonatal Intensive Care Unit, the NICU.
It took me about 2 weeks to visit the NICU without leaving in tears. And it's a catch-22 because you want to be there all the time, but at the same time it's so hard to be there. Hi, Jen, how are you?
For the LePaps, parenting now means running between home and work and hospital. The joys of bonding with their firstborn are often overwhelmed by anxiety.
I know, another IV.
And the challenge of decoding the complex workings of high-tech neonatal medicine.
It's a crash course in the care of premature babies. It's a whole new world of conditions and terms and acronyms. And we're also going to be changing this formula around a little bit based on his electrolytes that came back last night.
Hollis Caswell is a nurse in the unit that cares for Alex.
We give them a lot of information up front. And oftentimes they understand it at the time that they're talking to us, but then they go home and they're like, what did she say? Or I'm not really clear on that. Hello. We're good. Alex, a little cold this morning?
But the LePaps have some help to stay on top of it all. Thanks to a new program funded by the National Library of Medicine, they can maintain close contact with Alex and his medical staff without spending 24 hours a day at the hospital.
We've added technology using the internet and allowed high tech to become high touch.
Dr. Charles Savron helped develop Baby CareLink, an experiment in telemedicine.
We hope that this also enables parents and extended family to bond sooner with a child who will be in a hospital for 3 or 4 months.
While the most important consultations are done in person, the LePaps can stay in touch with video conferencing. A secure website gives them daily updates on Alex's progress, reliable information on treatment and medicine, and a photo album that family and friends have access to.
Our families don't live in Boston. Mine is on the other side of the Atlantic. Jennifer's family is a couple of states away.
Sort of bringing the far-flung family close in and allowing them to follow his progress and see how he's doing. Okay, good.
CareLink's developers claim the program is cost-effective. Their research indicates that because parents are better prepared to care for them, CareLink babies can go home earlier than most other preemies.
On average, 2 days sooner than without the technology. That's roughly a $5,000 to $6,000 savings in the care that this child received.
For families and hospital staff, it's another demonstration that information is power. In this case, the power to cope.
You can sort of deal with things at your own pace in the privacy of your own home as you sort of get used to, whatever the newest hurdle is.
The CareLink concept is now being expanded to provide similar services for families dealing with other long-term illnesses, such as cancer.
Yeah, just some, as I said, some limited studies done on this particular product. The results were a decrease in NICU stay of 2.73 days, and the readmission rates for NICU patients using this particular modality was reduced from 40% to 18%. So here's a demonstration that the innovative use of multimedia technologies and the internet can actually have a direct cost benefit on the system. And I think, and I'm just going to free talk if I might, I think those particular areas, I wanted to spend a little time on genomics because I think that's probably the next era. I think what we'll see is we'll see the gene as really being the key to the electronic patient record, which has some really challenging debates in terms of the privacy issue, to be certain. And I really wish I could spend more time with that particular concept, but I think that is probably the hallmark change of the next era. For those of you who have some interest in innovation on a broad scale and on a very, very highly imaginative scale, I really urge you to have a look at the web page or even visit the University Health Network Center for Global eHealth Innovation. There's some very, very cool stuff going on in terms of using multimedia on websites to coach patients prior to coming in, the use of multilingual websites to assist people who are challenged in the English language, websites which use cartoons and other things for people who can't read. Some very, very innovative ways of educating people who would otherwise not have the opportunity to do so. The last thing that I want to touch on, and this is through a colleague of mine in Singapore, is the use of virtual reality in terms of rehab medicine and actually in terms of treatment of some phobias. Like fear of heights, fear of closed spaces. Virtual reality has shown that one can train people to overcome that fear within the virtual environment. I think that's going to be a very, very exciting area in terms of using some truly modern innovations in the care of people. I have to apologize that I probably spent a little too much time on some things. I don't. And not enough time on others, but that's the way it goes. I was a little rattled, I guess, initially. So I do thank you for your coming here and listening to me, and I hope in some way that I've been able to illuminate some spots of darkness or perhaps cloud over some spots of sunshine. So thanks very much.
Well, if any question, we have a few minutes left for questions and comments, and it might be a chance to ask Steve questions. Yes?
Every hospital has an IT plan now, Stephen. What would you say are a couple of flaws that you see in these IT plans? What are the big mistakes that an enterprise makes when it puts the plan together?
I think it's probably the balance of power between IT and the user. I think we still have a very hierarchical approach and a very patronizing approach to users in terms of IT administration. Now, it's like the old days of a chief financial officer to tell you what to spend, what not to spend, as opposed to sort of understanding the role of being custodian of money as opposed to.
Anything else?
Involving more clinical people in your implementation teams and in your project teams. I think that's the key. You have to overcome the cultural barrier. I think the only way you can do that is by putting people together who understand what the user is doing from a practical point of view.
Yeah, you said that the pharmacy information network addresses patient privacy. How does it do that?
The way that PIN works specifically is that you understand the situation where I can get a medication and not allow anyone to be told. And the great danger in that is that a physician who doesn't know that you're on that medication, probably the most typical example is Viagra, where people will sneak off and go to a doc in a box to get it, and their regular physician doesn't know and then prescribes some antihypertensives, which together with Viagra can do a real nifty job of getting rid of you. The way the PIN project works, it simply says there is a medication in this patient's record which is contraindicative of prescribing this one. And your option as a physician is to say, hey Dominic, there's a prescription that you haven't told me about, so either tell me what it is, or I'll have to refer you back to the physician who prescribed it to deal with this problem because I can't deal with it. So it's an optional kind of approach, but it overcomes the essential dangers of that privacy kind of implicates in that particular situation.
There's a question over here on this one, if not, over here.
From your presentation, it would seem fairly obvious that innovations and adaptations of RCT is continuing to sort of follow the traditional medical and/or health approaches to healthcare. So there's still fragmentation. And I think that seems visible in the medical record as opposed to the health record. Feel free to tell me that there's something different happening there, that the two are coming together to be truly innovative, to truly attack the broad continuum of what creates health.
I think there's hope at the end of it as home care, community care, extended care become part of that. I think the great challenge that we face is the fact that we haven't been very prudent in terms of keeping pace with technology. And now we find ourselves in a position where to get up to technology, to get up to speed is a gargantuan leap. And you're quite right. I mean, there's no question that the continuity of a health record, irrespective of where the service is provided and when it's provided, is very, very important. But there's a cost and mentality, I think, involved in that, which I don't think we've stepped up to yet.
Just a follow-up question. You also talk about the American dominating our market very quickly, if not now, with their products. But I would have to put the argument forward that there's fundamental differences in the way our healthcare systems operate that can ensure that Canadians can be innovative and come up with their own. That the American models coming up are not truly understanding those differences. And so we are, left with a product that's not going to substantially fit our needs up here, and it is a critical fit, I think.
Well, I don't disagree with you at all, but I think the reality is, and there's two realities involved. Number one, I think it's pretty, like the dominant vendor in Canada is Meditech, period. Like they own a heck of a lot of our facilities, and the rest you can start ticking off from Cerner to McKesson to Eclipsys, and so on. And except in relatively small communities, you see Canadian vendors participate. And the problem is not so much is there a difference in system, because many of the functions are relatively similar in terms of a structural HIS. And even if it wasn't, the problem is we have hundreds of millions of dollars invested in this. And I honestly can't see someone saying, oh, well, like Nova Scotia, for an example, let's dump Meditech and get something else. You know, politically you can't do that. And so I think the solution will be that I think Canadians have had a reputation in niche markets. We're very, very good at some things which are very, very focused. And we have like telehealth, telemedicine. We're world leaders in that. Telerobotics, Kingston, for an example, is acknowledged internationally. In home care, believe it or not only do we have our own market, like there are virtually no Americans in the home care market in Canada. And Canadian companies are starting to, well, Procura, for an example, out of Victoria, virtually owns the state of Texas in terms of that product. We're that good at it. We're that good at it. And I think, as anyone else, what you do is you leverage on your strengths and not leverage on your weaknesses. So, and I think the other phenomenon, which I think I alluded to earlier, is that what we're going to see is we're going to see much more specific clinical systems. You know, for an example, in my particular field of interest, which happens to be transplantation and dialysis, currently there are no information systems which support that process. And there's a very unique view of the EHR from a dialysis perspective, which differs from a cardiology perspective, which differs from other patient-specific perspectives. And I think the way that we will see clinical information systems go is to support very highly specialized areas of medicine and care. And we will start to look at markets not in terms of how many hospitals, but we'll acknowledge that the marketplace is restricted to university teaching hospitals or highly specialized hospitals, but we will look at those in terms of a global context. That we will not look at the Canadian market, but we will look at an export market, and we'll look at an international market. And that's just the way I happen to see it. But there's so many realities in terms of investments that we've made, or which would prohibit us backing out of the American system into now.
We're really at the end now, but I'll take one more quick question from you.
I just noticed that you didn't have anything on this slide sort of looking forward as kind of key opportunities around evidence-based medicine. So you had an earlier quote from Larry Reed, and in context of that, where do you see that going? Or
I see it being here.
Sorry?
I see it being here. Evidence-based medicine, I think, is part and parcel of that.
What about the company opportunity in terms of the IT in Canada?
Well, exactly as I just stated, as we go into clinical system, evidence-based medicine, knowledge systems, that entire entity will take a far, far more significant role than it has in the past on a commercial basis.
I'm sorry that we have to end. This could be a lot of fun, but I want to give people a chance to get home and all that. Thank you very much, Steve.
Before people leave, I just have a couple of things I want to mention. The slides that will be provided and ones that we didn't see as well will be available on our website probably in the next day or so. And the videotape of this session, as are all of the videotapes of these sessions, are available on our website as well. That's intranet.uwerly.ca. The last thing, if you want to become part of our announcements list or get receiver announcements or anything else that we provide in terms of email or physical mail, please give me your business card or drop off something that I can provide you the information. I'd love to send it out to you.
Sure, could you just more slowly mention that website?
Intranet.uwerly.ca. INFRANET.UWERLY.ca.